Okay, so for the last 40 minutes now, we're going to concentrate on human viruses. And so we'll start with some general aspects, then we'll look at two examples, influenza and Ebolavirus infection. Now, generally, when you talk every day about getting a virus, what you're talking about is, oh, I felt a bit sick for a couple of days and I'm better now. So the idea people have of a virus infection are these kind of acute infections where you get infected, a few days later, a couple of days later, you'll have a peak of viral infection, you'll develop symptoms, and then you'll get better. So that's, rhinovirus, common cold, norovirus with viral gastroenteritis, hepatitis A, in most cases you have resolution like this. There's some acute infections don't work out so well. Okay? In this case, you'll have a peak of viral replication, then symptoms which get progressively more and more severe, and then you may die. So this is an alternative outcome of an acute infection. Now, some viruses will kill almost nobody who gets infected, like common cold virus, rhinovirus. Probably like nobody gets killed by these acute infections. On the other end of the spectrum, you have rabies. Almost 100% of people who get infected, if they aren't treated, they'll die. Ebolavirus is also highly pathogenic. In the current epidemic, there's about a 70% case fatality rate. If you're diagnosed positive, 2 chances out of 3 is that you'll die. And then in between these extremes, you have other things like influenza, seasonal influenza, maybe 1 person in 1,000 will be killed. Severe acute respiratory syndrome virus, the SARS virus, that might be killing 15% of people. So you have a kind of spectrum of outcomes here, from like almost completely harmless to very, very, very pathogenic among acute viruses. As well as acute infections, viruses can cause persistent infections, which can either be latent or chronic. So what's the difference between these two? In a latent infection, you'll have a primary infection, so you get viral replication, then you get symptoms, and then apparently you seem to get rid of the virus. You can't detect the virus replication afterwards. This is the latent phase. However, the virus is still somewhere in your body, and periodically, years or maybe decades afterwards, virus replication can be reactivated. And then you have a peak of viral replication, you have symptoms which recur, and then, the virus will disappear again. And these cycles of latency, reactivation, reappearance of symptoms will repeat, probably over the lifetime of the person. So the big, professionals that are doing this are the herpes viruses, herpes simplex, cytomegalovirus. They cause latent infections. Chronic infections are a bit different. So you have, again, a primary infection, which is more often than not symptomatic. Then you'll have a kind of partial control of the viral replication, but there will always be active viral replication that can be detected. And what happens with chronic infections is that, over time, symptoms will get worse, and these chronic diseases will tend to go towards more severe pathology and maybe death. But the whole of this process can take many years or decades. So viruses that have a chronic infection, there's like hepatitis B virus or hepatitis C or HIV infection, untreated HIV infection. So you may, all the people with a chronic viral infection may not actually die because of that, because the rate of progression can be very, very slow. So for hepatitis C, if you've got chronic hepatitis C and you aren't treated, you probably have about 50% chance of being killed by your chronic viral infection, and the other 50% of people will have a heart attack or get cancer or something, okay? Because, their hepatitis C hasn't had time to kill them yet. Okay, so this is the kind of spectrum of clinical diseases that can be caused by viruses. How do you catch viruses? Okay, that is just like pathogenic bacteria. All viruses have got to attach onto the host cell and gain access to the host somehow. So mucosa are the main route for many viral infections, either gastrointestinal, so you'll have oral transmission of viruses that cause gastroenteritis, hepatitis A virus, causes you catch it from food that's not clean, this kind of stuff. Poliovirus infects the intestine mainly. Okay, your respiratory mucosa, you can catch them by breathing infectious viruses in. Influenza, common cold virus. Measles, also caught by in the respiratory route. Genital mucosa, of course. Many sexually transmitted viruses exist. HIV and papillomaviruses cause cervical cancer. Okay, as for bacteria, the skin is not a very frequent route of entry for viruses. Viruses need a live host cell to infect. On your skin, you have cornified dead keratinocytes. Viruses can't infect these cells. But nevertheless, papillomaviruses, if you have a slight skin abrasion, you can get a wart on your skin, on your fingers or on your toes. Pox viruses can also infect directly to the skin, well, some types. However, transcutaneous infection is quite important. There are many viruses which are transmitted by insects or ticks. Yellow fever, dengue fever virus, and a whole bunch of unusual and infrequent viral fevers and encephalitides. So if you go hunting out in the forest and stuff like this, you get bitten by a tick. Sometimes you can get an unusual viral encephalitis because of that. Okay, blood. Any virus that's present in the blood and you transfer that blood to a new person, well, that can be a rote mechanism of infection. So blood transfusion, intravenous drug use, or organ transplants can transplant viruses. So, HIV, chronic hepatitis, they can be transported by blood. And these latent viruses as well, they'll have latently infected cells in the organs that are transplanted. So when you transplant the organ, you can transplant the virus into the person who receives the organ. So all of these mechanisms of transmission are a little bit dependent on technology. So not really the main motors of natural transmission of these viruses. Another one that is very important, not to forget, mother-to-child transmission. Viruses can be transmitted during pregnancy or during birth. And that's very, very important for HIV. If a woman is HIV positive, not treated, maybe about a 1 in 3 chance that the baby that's born will contract HIV infection during birth. Hepatitis B as well, this is the main mode of transmission of this virus in countries that have a high rate of infection, like in South Africa. Okay, so identifying the infection route, very, very important in order to prevent infections, to put in place the correct preventative measure. You've got to know what the transmission route is. Okay, there's no point wearing a preservative if you want to prevent influenza infection, right? It's not going to work. No point wearing a mask to prevent HIV infection. You have to adapt the preventative measure to the mode of transmission. So that's how viruses arrive in your body. Once they get there, what happens? There are 2 types of viral infection, local and systemic. So in a local infection, replication will be limited to the initial site of infection. There will be no viremia, so no virus in the blood, or very small amount. And typically you'll have a short incubation period. So the incubation period is the time between the time between infection and the appearance of symptoms. This will be short. So that's typically like a rhinovirus, okay? Common cold virus or influenza. You get infected, you'll have symptoms within the next couple of days. Same for viral gastroenteritis. You get infected, it arrives in the gut, the only site that's affected in your body is the gut. And symptoms occur rapidly. In a systemic infection, then the target organ, that's the organ which provokes symptoms when the virus infects it, is distinct from the site of infection. So that means somehow the virus has got to travel through your body and get to the target organ. So that's why you'll always have viremia. You'll always have virus in the blood. And these infections are characterized by a rather longer incubation period, either intermediate or long. Long is like more than 3 weeks. So examples are hepatitis A virus. The site of infection is the intestine. The target organ is the liver. And you'll have transport through the hepatic portal vein. HIV, okay, the site of infection is the genital mucosa, target organ is the lymphoid tissue. Measles, site of infection is the respiratory mucosa, the target organ, what gives you symptoms is the spots on your skin, right? So the target organ is distant from the site of infection. Okay, so those are general features of viral infections. So we'll have about 10 minutes on influenza and maybe 20 minutes on Ebola virus, just to give a little bit of a contrast. Okay, influenza. It's an orthomyxovirus, and the orthomyxoviridae, it's a family level designation, consist of influenza viruses A, B, and C, and the Fagotovirus, which does not infect humans, I believe. So the ones we're concerned with are influenza viruses. Influenza C is very often asymptomatic, so it's not very pathologic, and we don't really care about it very much. A and B infect people and cause symptoms. So these are the ones that are incorporated into the seasonal influenza vaccine, which is composed of 2 influenza A serotypes and 1 influenza B serotype. These viruses, what they look like. So they are envelope viruses. You can see them in electron microscopy here. That's the envelope, with envelope glycoproteins all the way around. Particles look round or oval. But in fact, when you look inside, the nuclear capsid is helical. So you have inside every virus particle 8 segments of the genome, which is negative strand RNA, together with the nuclear protein. So these nuclear protein complexes are rod-shaped with a helical symmetry. So the particle looks round, but in fact the nuclear capsid is helical. Now, why do we have 8 genomic segments in here? Basically, each segment of the genome codes for 1 gene. So in order for the virus to have a whole genome inside the virus particle, it's got to have 1 copy of each of these segments incorporated into the particle. Otherwise, it won't be infectious. Okay, just a couple of elements of basic virology. So the glycoproteins on the surface, you have the hemagglutinin. This is the attachment glycoprotein. Allows the virus to attach to host cells and is also involved in entry. Neuraminidase, this is involved in release. So if you don't have the neuraminidase, all the virus particles will stick back onto the infected cell and will not be released effectively. For the nuclear protein segments, these consist of the viral RNA, maybe hundreds or thousands of copies of the nuclear protein, and then the viral RNA polymerase, which is composed of the polymerase A and B1 and B2 subunits. These have to be packed inside the viral particle because it's a negative strand virus, right? This virus is negative strand. It doesn't code for RNA. So in order to express the gene, the virus has got to transcribe this negative strand RNA into plus strand RNA. And this can then be translated into protein. But the host cell doesn't have an RNA-dependent RNA polymerase. So the virus has got to bring it with it, together with the genome. So that's why you've got an RNA polymerase here. It's absolutely essential, otherwise these genes can't be expressed. Okay, influenza. What happens if you catch influenza virus? You get infected through your respiratory mucosa. Maybe 99 times out of 100, the upper respiratory mucosa. Okay, because the droplets that contain the virus will be deposited on your upper respiratory mucosa. It won't go into the lungs in most cases. Then after that, so you'll have the epithelial cells that are in the mucosa will be infected. They'll produce virus. 2 days later, you'll have symptoms, and that will be fever, fatigue, and muscle pain, headache, maybe a cough, not necessarily. Probably talking about fever, fatigue, muscle pain. This is a triad. It will be important. Then symptoms will persist for 3 to 5 days. You might feel bad for the next couple of weeks, and that will be you. You'll be fine until the next time you catch influenza. That's seasonal influenza without any complication. Complications, what can happen? Well, you can have a bacterial superinfection. You can be more susceptible to a streptococcal pneumonia infection. Or the virus can manage to escape from the upper respiratory tract and manage to replicate in sites that are nearby. So you can have a viral pneumonia or bronchitis, which is slightly more severe than just an uncomplicated influenza infection, or otitis. So it's with seasonal influenza, maybe a third or a half of infections in young healthy adults might be asymptomatic. You won't even notice. But in elderly people and young infants, then you'll have a higher incidence of more severe infections. And the overall mortality rate may be about 0.1% for seasonal influenza. So even though the overall mortality rate is not that high, it's important to vaccinate vulnerable groups. So people over 65 should be vaccinated every year. Children who have an underlying condition, who may have a may develop bronchiolitis in response to viral infections, they should be vaccinated every year. And also healthcare professionals, people who are looking after elderly patients, they should always be vaccinated, because someone who's got an asymptomatic infection, you won't know that you're infected, but you can still transfer the infection to someone who is very susceptible. So if you're working with older people, you should definitely get vaccinated every year in order to protect the people you're working with. Now the problem with the vaccine is the virus is evolving over time. It's antigenically unstable. So the vaccine has got to, every year there's a meeting of influenza experts to decide what is the virus strain we're going to put in the vaccine for this year. So this is the change in the vaccine strain over time from 1970 to 2002. So this was the H3N2 strain, had to be changed several times over 30 years. The H1N1 strain, a little bit more stable, and also the B strain has to be changed regularly. So this phenomenon of the virus that doesn't stay still over time, it's mutating, it's escaping from the antibody response in the population over time. This is called antigenic drift. And this is one of the reasons why people think that the influenza vaccine is not effective. Because if you get the vaccine, you'll have antibodies against that particular strain. If you're unlucky, next winter season, the virus that is actually circulating might not be the same strain as the one used for the vaccine. So in that case, you may still get influenza infection, because there's a mismatch between the vaccine strain and the virus that's actually circulating. So this is a problem in influenza virus vaccinology. Now another problem that occurs that's specific for influenza virus is something that occurs because of the segmented structure of the virus genome. So if you've got two different influenza viruses that infect the same cell in the same person, I call them virus A and virus B. One of them is human, one of them comes from a bird. This infected cell will replicate the viral RNA. And then when these RNA genomic segments get encapsulated into a new particle, you may get a virus, a mosaic virus, that has some human gene segments and some avian gene segments. And this could be something very, very new. This could be a new virus that has never been seen before. And this is important because it seems to be involved in what's called antigenic shift. That is the sudden appearance of a new strain of influenza virus, and nobody has got immunity to it. So this virus can have a huge success and infect everybody in the whole world. So antigenic shift is the motor behind what's called pandemic influenza viruses. The pandemic influenza virus is a new strain of influenza. Nobody's got immunity to it, and you can have a lot of people infected. So over the last 100 years, there have been several pandemic influenzas, and they're defined by the serotypes of the hemagglutinin and the neuraminidase protein. So the envelope glycoproteins define the serotype. The last one was in 2009. This one was very, very mild. It was not very pathogenic, perhaps less even than seasonal influenza. But some of them have been very, very severe, like the Spanish influenza. Okay? That maybe had about 5 to 10% case fatality rate. It infected millions of people, probably killed more people than World War I, this virus. So, as I said, these pandemic viruses occur either because you have a mix between a human and an avian virus, and this gives you a kind of mosaic. That's what occurred here, that's what occurred with the Mexican flu. Or sometimes you can have the species transfer of an avian virus to humans. That's what occurred for a Spanish flu. Okay, it didn't actually occur in Spain, but it was the Spanish press that reported the first cases, apparently. So in this case, you have adaptation of an animal virus to humans, and the result was a much more pathogenic virus than normal human influenza virus. Okay, so now I'm going to finish up with Ebola virus. Probably spend about 20 minutes on this. We might go slightly over time, but I hope you'll bear with me. Okay, so in terms of basic virology, once again, Ebola virus, the Ebola viruses, have a negative strand RNA genome, but this time it's not segmented. You've just got one RNA molecule that codes for all the viral genes. Okay, compared to influenza, it's genetically more stable. There's been less variability in Ebola virus genomes over the last 30 years than influenza. So maybe this is due to more higher fidelity of the polymerase enzyme, but it could also be due to the fact that there's no kind of competition with the human immune system to select for variants. Okay. Now within the genome, okay, what have you got? The L, this codes for the viral polymerase. NP, this is the nuclear protein. There'll be a matrix protein in there somewhere as well. Glycoprotein, that's on the surface. Then you have these proteins, VP35 and VP24. So in terms of pathology and control, the important things are VP24 and VP35. These two virus proteins inhibit the host interferon response. Okay, so we'll talk about that a bit later. Now the surface glycoprotein, the G protein, this is what's on the outside of the virus particle. It's the viral attachment glycoprotein. It allows attachment and entry into host cells. If you get antibodies against the G protein, they'll fix onto the virus. It won't be able to infect cells anymore. So all the efforts to develop a vaccine are based on the viral G glycoprotein. Okay? So the idea is give the vaccine, people will get antibodies against the G protein, and the virus will not be able to infect cells. So there are three candidates that are have been very rapidly advanced to human clinical trials. Okay, so they're all basically expressing the Zaire Ebola virus glycoprotein, G protein, and they use other viruses, harmless viruses, to induce the expression and induce the immune response against this glycoprotein. So all three of these vaccine candidates have very good results in macaques, in non-human primates. You give the vaccine one dose, then you infect with a high dose of highly pathogenic Ebola. All the animals are protected. So a good reason to think that these vaccine candidates will be successful in humans. So I'm quite hopeful about this. But you need to be sure, and you need to be able to produce enough of these vaccines for it to make a difference. And there's a real race going on at the moment to make this happen. Okay, Ebola virus, what is it? Let's do a bit of phylogenetics here. I said the genome is negative strand RNA in one single molecule. So this is what characterizes the mononegavirales order, which is composed of several different families of viruses, rhabdoviruses, so this is like rabies virus and associated viruses. Paramyxoviridae, this is measles is one of them, for example. Respiratory syncytial virus is another one. And then Ebola virus is one of these filoviridae. Okay. Filoviruses are characterized by their very, very clear arc, which I didn't say. Because the particle morphology, this very, very long filamentous viral particle, you can see here in electron microscopy. So this is what characterizes this virus family. Okay, apparently there are 3 genera in the Filoviridae: Marburg viruses, Ebola viruses, and love you viruses. Rather strange name. And these ones apparently are less pathogenic. Marburg and Ebola, both highly dangerous. Now, when I talk about Ebola virus, this is a genus level classification. Okay? And there are 5 distinct species of Ebola virus which occur in different regions of the world. So most of them are in Africa. Zaire Ebola virus, these are different epidemiological centers of this one. And this is the virus that's causing the epidemic in West Africa now. It's a Zaire Ebola virus. We also have Sudan Ebola virus, another one which is Bundibugyo Ebola virus, and one in Côte d'Ivoire which is called the Thai Forest or Côte d'Ivoire Ebola virus. There's also one called Reston Ebola virus, which has been seen to occur in America and in the Philippines. Okay, so from now on, I'm going to be talking about the Zaire Ebola virus. Okay. So when I talk about Ebola virus infection, I'm talking about this one. So for generally Ebola virus, okay, I said that, but now I'm going to talk more generally about Ebola virus infections again, all of them. So this graphic, I just wanted to put this because it's got a lot of information. Probably, if you want, you could read it from the slides. But the thing I want to talk about here is that it's got a good graphical representation of all of the different Ebola virus outbreaks that have occurred since the viruses were discovered in the 1970s. So each one of these columns here is a different outbreak, right? And each dot is one person that is infected. And a black dot is somebody who dies, and a red dot is a survivor. At the back, this was published in August, so already in August, this is the 2014 outbreak. It's already the biggest one that had ever occurred. Now, for Ebola virus, often you can hear something like on the news or on the television, the mortality rate can be up to 100%. Well, that's true, and it's not true at the same time. It's true for this outbreak. You have one person infected, and he died. You have a 100% fatality rate. But that's just a statistical artifact, okay? And again, here you have another outbreak. I think you have one person infected, one person died. So to get a clearer picture of what's going on, you've got to try and average out all of these different outbreaks. And what occurs when you do that is Zaire Ebola virus has got a case fatality ratio of about 78%. Sudan Ebola virus a little bit less, 23%, and the Bundibugyo Ebola virus 1 in 4. All of these are extremely high, alright? What do we see for seasonal influenza virus? 0.1%. So these are like hundreds of times more pathogenic than a seasonal influenza. Now, another thing you might notice here is that, you know, from between 1996 and 2000, there were no human cases of Ebola virus infection. So after 1996, where did this virus come from? Well, what appears to be happening is that the humans are not the natural host of this virus. The natural host is a bat. They're bats who are persistently infected with this virus. And from time to time, an infected bat can either transfer infection to another animal, and then either these bats or these animals can be hunted for food and eaten by people. So there have been documented cases of the first person in an outbreak to have Ebola virus infection was infected through a bat. And probably it's not because of the cooking or anything, but when you've got the animal, you've got to prepare it, right? You've got to skin it, cut it up and this kind of thing before you cook it. So your fingers will be coming directly into contact with blood that's got a virus in there. So this is how transmission occurs from time to time from the animal reservoir to humans. That's where this outbreak comes from. That's where the present outbreak came from. And then you can have transmission from human to human. And depending on how efficient the transmission is of the virus between humans, either the epidemic will just infect 10 people or 5 people or 100, or as we've seen now, we have thousands of people who have been infected by this virus. Okay, so if you get it, right, from a bat or from another person, what's going to happen to you? Okay, you'll be infected through the mucosa or transcutaneously. Doesn't need very much, an abrasion or a cut on your skin, and that will be enough to infect you. Firstly, you'll have an asymptomatic phase. Currently 2 to 21 days, you'll have no symptoms, you won't know you're infected. The average of all Ebola virus outbreaks has been 8 to 10 days. Apparently for this West African epidemic, it's about 11 days, average incubation period. Then you'll have early symptoms. Fever, fatigue, muscle aches, myalgia, headache. All of these are very, very non-specific. Vomiting and diarrhea. You have this for 2 to 3 days. This is why it's difficult to diagnose. Okay, fever, fatigue, myalgia, headache, the same thing as influenza, right? We just saw that. So often this could be called a prodromal phase, where people get symptoms, but the symptoms are very non-specific. Then afterwards you'll have a rapid deterioration, very, very high fever, greater than 38.5 degrees. People will have become like totally knocked out, become very passive, perhaps have blood in the vomit. Things will get worse. You may have bleeding from all your orifices. Then in the end, people will lose consciousness, have internal hemorrhage and die. And it happens very, very quickly. So there might be 8 days between the first symptoms and death here. So people who are killed by Ebola virus are diagnosed, they'll have a short hospital stay if they don't recover. So if you survive the first week, probably going to be alright. Okay, what is happening? What is happening? Why is this virus making people so ill? Okay, so initially the virus is going to arrive in these mucosal sites or in the skin abrasion, going to infect cells locally, cells of the immune system like dendritic cells, Langerhans cells, and these cells will then transport the virus all the way through the body to the other sites of infection like the liver and the spleen. However, this dissemination occurs without activation of the immune system. And that's because of these viral proteins, VP24, VP35. They put your immune system to sleep. You know, you're infected, but nobody knows it's happening. And this is what allows the dissemination of the virus throughout your whole body. Then later on, you get a very, very high viral load. So finally, your immune system wakes up. Oh my God, you've got virus all over the place. So you get a huge activation of your immune system, of the bathroom monocytes, macrophages. By this time, it's too late. You've got virus everywhere. So you've got very, very strong systemic immune activation. And this is what causes the symptom, alright? So you'll have a lot of these inflammatory mediators. You have a very, very high fever. You have these coagulation factors produced by macrophages, which will cause intravascular coagulation. So you'll use up all of your blood clotting factors in the blood. All the rest of the blood will become very, very much more difficult to clot. You'll have vascular leakage. All the endothelial cells will become more permeable. Blood pressure will go down. People who don't get hospital treatment, this is going to be the main cause of death. They'll have a hypovolemic shock. Their multiple organs will not be irrigated enough, and you'll have multiple organ failure. You will die. Hospital treatment, just by giving you replacing fluids, is a big help. Does this remind anybody of any kind of pathology? Endotoxic shock. It's a similar kind of mechanism. The trigger is very different, but the mechanism is really quite similar. Okay? You've got a massive activation of your immune system, and that's what's going to cause the pathology. The same thing in endotoxic shock. Okay, one thing that we have to be clear about, it's important everybody gets this right, is the mode of transmission, because there's a lot of information in the news, on the web, about people who are worried about this. So, to be infected, you have to have contact through with the infected blood or body fluids, direct contact. Body fluids can be feces, vomit, could even be sweat, maybe saliva, maybe even tears or breast milk. Now, when are people infectious? So there's no evidence of transmission during the asymptomatic phase. People who are infected become dangerous, become contagious after symptoms develop. And as the disease progresses, you have more and more virus, you have a higher viremia, so people become more infectious. And after death, the bodies are still infectious. So the virus that will be in the blood or in the feces or on a dead person's body is still contagious. Okay, one of the things we have to be clear about is that the Zaire Ebola virus is not airborne. There's a lot of people, I've seen people worried about this. Is it going to get airborne? Is it airborne? Why do the people have to wear a big face mask if it's not airborne? The government's not telling us something. They just don't want to worry us. They don't want to cause panic, so they're hiding things. Okay, so there's a difference between droplet infection and airborne infection. Droplet infection, okay, is you have somebody who might be coughing or vomit or something like this, and this is infectious. You have droplets with infectious virus and they're being projected from the infected person. That would definitely be a risk. These things are dangerous. And that's why people who take care of Ebola virus infected patients need to wear masks, because they may have these droplets that are projected onto them. However, these droplets are quite large. They won't persist in the air. Either they'll hit somebody, or they'll fall down onto the ground, and then this area will have to be decontaminated. Smaller particles, alright, very, very small particles that have less than 5 microns in diameter, these kind of like liquid droplets, the water will evaporate and you can leave the solid material will be able to remain in the air. Some viruses can remain infectious in this state. Now, maybe the best example is of an animal virus, foot and mouth virus. So in that case, these dried out particles can float around in the air and can infect people at a longer distance. That's what is meant by airborne. Okay? And Ebola virus, Zaire Ebola virus, is not airborne in that sense. Okay, so droplets can infect you, but this airborne stuff can't infect you. Okay, so how do we know that what I just said is right about asymptomatic people being non-infectious? Okay, well, the best data I've found on this is a study of control of Ebola virus disease in Liberia. So over the summer, at this rubber plantation, the Firestone rubber plantation, they had an outbreak. There had 71 cases, 70% death rate, but over a month and a half, they managed to contain the infection. So how did they do it? They made sure everybody who was infectious, was symptomatic, got isolated. They identified the contacts of all the people who had an infection, and then they had 2 types of follow-up. For people who had a high-risk contact, they had to be put in quarantine. So high-risk contact, that is, they had percutaneous contact on the skin or through the skin, or mucosal exposure, or skin contact with blood or body fluids from a person who was symptomatic or an infected body. That's a high-risk contact. And they've identified 159 low-risk contacts. These are people who might have been working together with one of these people, just on the same job, but didn't actually touch them or have a high-risk contact. Or it might have been a family member living in the same house during the asymptomatic phase. They had a contact with an infected person. So these were defined as a low-risk contacts, and they could be quarantined, or they were also allowed to stay at home and have a follow-up. So who developed an infection? Okay, in the high-risk group, there are 21 people infected, 53 people non-infected. So 1 in 3 chance of becoming infected here. In the low-risk group, nobody got infected, everyone was not infected. So really, these low-risk contacts with somebody with asymptomatic or beginning to develop symptoms are not very dangerous. Okay, so this virus is not hugely contagious. Okay, so where is this epidemic going? Why should we be worried about this thing if it's not so contagious? This is from another slide from Ian Mackay's blog, like the droplet one that I just showed. And it shows the cumulative number of total cases from June through to the beginning of October. And it shows the fold change per month. So from June to July, you go from 400 cases to 800. You get about a twofold increase. July to August, 800 to 1,700. August to September, 1,700 to 4,000. September to October, 4,000 to 8,000. So up until the beginning of October, we have an exponential increase in the number of cases, with a doubling time about every month. This is what is scary, right? Because that means that you're getting a factor of 10 every 3 or 4 months. So now we're talking about, okay, beginning of October, 10,000 cases. If this epidemic is not controlled, we'll be talking about 100,000 cases in February. And we might be talking about 1 million cases in June or July next year. That's a lot of people, and probably 70% of those people will be killed. That's a serious problem. So what can be done about this? That's why they're developing the vaccine. It has become a very, very high priority. But until the vaccine becomes available, what can be done to try and control this epidemic? So this has just been published in Science. It's a study of epidemiological modeling, trying to find out what's the impact going to be of different control measures. What should the countries be trying to do? So these are the different options they're testing out. Hospital case isolation, right? That this, if you get people who are symptomatic, put them in hospital. Or you try and make sure that all the people who have been killed the dead bodies are taken care of and disposed of safely. This is one of the main vectors of transmission in this epidemic, is that people who have been killed by an infection, they get buried by their families, they get moved to their home village and this kind of stuff, so they have dead bodies being driven around in a taxi. It's dangerous for the people who come in the taxi afterwards and the driver. At the funeral, all the relatives come and hug the dead person and say goodbye, and it's risky, it's dangerous, it's a mechanism of transmission. So if you could stop that and have safe burial, let's see, if it was 90% effective, just doing that, you could probably stop the epidemic within 6 months. The other thing you can do is try and trace all the contacts and put them into quarantine. That's D here. This would also be very effective if it could be done with everybody. And that's going to be very, very difficult to do. We have like 10,000 people who have been infected now. Oh, in fact, the numbers for beginning of November are 13,000 cases. You've got 13,000 cases, you've got to try and track all the contacts of those people. The job just gets more and more difficult as the epidemic progresses. So then they thought, okay, what if we can't do any of these things at 100% efficiency or near it? It's just not possible. What if we try and do everything with partial efficacy? Trace the contacts, put them in quarantine, make sure bodies are disposed of correctly, isolate the cases. Okay, if you do that with 60% efficiency everywhere, this epidemic will be finished in 6 months. So that's where all the effort is going now. And it's a question of resources. Okay, if there are enough resources, enough people, then it can happen. Right, so that's nearly the end now. So the summary for viral infections in humans. Don't forget, viruses can be acute or persistent, local or systemic. You can have a diversity of clinical outcomes for each infection. For influenza, you may have asymptomatic cases. You may have some people who are killed. Differences between these two viruses, these are the key points. I know I've gone over time a little bit, but I want to show you this last slide, because these kind of graphs, you've got 10,000 people killed and this kind of stuff. It's difficult to visualize what that means. And as you may know, the healthcare workers are in front line. So here are some people who have been killed by this virus in Sierra Leone. Mbarufuni, Alex Mudboy and Alice Corona were nurses. They got infected, taking care of people, and they died. Mohammed Fuller was a lab technician. Many members of his family were killed. It's not clear whether he got infected at home and was killed, or whether he caught the infection at work and infected his family members. Dr. Sheikh Umar Khan, this guy was the leader of the hemorrhagic fever unit in Sierra Leone. This was their number one top infectious diseases guy. He got killed by the infection. In Nigeria, now you may know that in Nigeria there are no Ebola virus cases at the moment, and that's largely due to the efforts of Dr. Stella Ameyo Adadevoh. Now, there was one importation case over the summer. It was a Liberian man who was a government employee from Liberia. He traveled to Nigeria to attend a regional government conference. He got sick when he was in Lagos, and his attending physician, Dr. Adadevoh, correctly diagnosed him as having a suspected Ebola virus infection. So she put him in isolation. Now, this guy was not a very cooperative patient. He didn't want to stay. And according to articles on blogs, at one point he pulled out his intravenous line, splayed blood everywhere, and tried to walk out. And the hospital staff had to just physically stop him from leaving. So that's one of the things that Dr. Adadevoh did, and unfortunately she contracted the infection and she was killed by it. So she was not the only person who was involved in this effort. It was a team work by all the medical staff involved. And they actually managed to trace all the contacts. There were 19 secondary infections. I believe all of them were in the hospital from this one guy. But they made a big effort to trace all the contacts and prevent further chains of transmission from being established. So their efforts really did save Nigeria from a really big problem.